really cool thing about the respiratory system. We only go, even all the systems actually, we only do an intro, right? The amazing thing about the body is it's very complicated, okay? And depending on where you are going in medicine, depends on how much you need to know or how much you don't need to know, right? So some of this stuff, even that we learn in here, you're sort of learning and you let that go away. Some of it you'll need to know. I can guarantee you in anatomy and physiology too, for all the majors, you'll need to hang on to this information, okay? It will resurface again. However, it's just a lot of physiology, how it works. The respiratory system gets quite complicated. I've told you before, like at the beginning of school, we take for granted when we take a breath. Okay, we really do, because it's actually very hard. A lot of things have to work together in order for us to take a breath. So, before I forget this again, let's talk about this. This is just definitions at first. Respiratory and metabolic, either you're neutral, okay, which that's probably what we are right now. We don't have acidosis or alkalosis, okay? But you will hear about metabolic or respiratory acidosis, which is most common, okay? And metabolic acidosis or alkalosis. Obviously, acidosis on the respiratory side is greater than 45. This confused me for years until I had to sit down and just sort of think about it and think through it, because the normal CO2, 35 to 45, acidosis is this way. 45 or greater is acidosis. Okay? Acidosis on the pH scale, it's this way. It's less than 7.35. Become acidotic. So either you have respiratory acidosis or alkalosis, so you would take the CO2 value. And if this patient, in general speaking, and now again, this gets to be more complicated, but we don't need to go there, okay? And we won't for both of our sakes. But respiratory acidosis, one thing that they look at is the CO2. So if this person's in respiratory acidosis, possibly, not saying, but possibly, their CO2 is greater than 45. Does that make sense to everybody? So later, when we get into our patient assessment, we start looking at end-tidal CO2, 35 to 45. Greater than 45 is acidic. Okay. Metabolic acidosis, the pH is less than 7.35. So they're going towards the 7, 6s, right? So that would be metabolic. You can have both. You can have respiratory and metabolic acidosis and alkalosis. Alkalosis is not as common as acidosis. Right? So wanted to bring that. I've been meaning to do that for some time. Okay. So when we look at the respiratory cycle, we have a rate, right? 12 to 20. We have a rhythm, irregular rhythm, right? And we have a pattern. And we have different respiratory patterns, which we will pick up shortly when we talk about diabetic emergencies. One respiratory pattern that we have, and it deals with CO2 or acidity, okay, in diabetic patients, and perhaps in DKA, diabetic ketoacidosis, okay, they get what's called Kussmaul respirations, K-U-S-S, Kussmaul. I've mispronounced that word for 20 years until a student corrected me. Finally, someone corrected me. I said Kush. I put an H in there somewhere. You know, like Texans leave off the T's on most things that they say. I put an H in there. Kush. It's not Kush. It's Kuss. K-U-S-S, Maul. M-A-U-L. Okay, Kussmaul respirations. right? And Q small is fast, deep respirations, right? They're fast and they're deep because this patient DKA is trying to get rid of this acidity. And one way that we get rid of the CO2 is what? Exhaling. And if we have an excessive amount of CO2, what does the body do to get rid of it? Breathe faster. Right. Increased respiratory rate. Always. Retention in CO2 will cause an increase in respiratory rate. That's very important to remember, okay? Because that's the way that we get rid of the CO2. All right. So we're talking rate and rhythm, pattern, and this video is on the Google Classroom if you get really bored and you want to watch it. But we're breaking it down, how these neurons help ventilation. Some of it we've already talked about. Okay, we talked about, this is the picture of the brainstem, in case you couldn't figure that out. Sort of the, I don't know if he's trying to draw the circle with us, it's been too long. Okay, but he's looking at hydrogen ion concentration or acidity, CO2, and oxygen levels. Okay, and what we've talked about is on the brainstem, the respiratory centers. Where are they located? Pons, very good. They're located in the pons, and we've only talked about really two, the apneustic and the pneumotaxic centers, those respiratory centers. And like it says up here, the pneumotaxic stops inspiration, and it sets the patient amount of stretch and time, okay? So there's, if I was to give, and you probably say, well, go ahead and do that quick, give this thing quick. If I was to do it quick, I would say that in one sentence or so, that the brainstem controls it by setting the rate and rhythm of the respiratory pattern. Okay? But it's far more complicated than that, because the fact that we're dealing with different signals that have to take place. Just like we've talked about, the body is full, the cells are full of receptor sites, and they're full of these little, what I call, this is not anywhere close to the right term, but on those cells are like little antennas, and they pick up signals, and they do things based on those signals, and they also do things based on voltage gates, like the cardiac cell. The cardiac cell, you know, we're at, which we will learn in March, is at -90. A resting cardiac cell is at -90 millivolts. So it's voltage gated. So you have voltage, you have signals, you have all these different things that control these cells. There's even a glue type substance that holds the cells together. All right? When we wash our hands with soap and water to get all the staph off our hands and all the stuff off our hands, okay, we use that soap, and that soap breaks down that cell membrane wall. Okay, it's the soap that does the work most of the time. These little weak germs, you can break it down with hot water. The stronger germs, they laugh. They like, oh, good, hot water. Ooh, good. I like that. You know, because it's not near hot enough. But when they get that soap, they're going, oh no, not soap. No. Now there's debate on whether they like hand gel. Hand gel, they're like, alcohol. Thank you. May I have another? You're right, you know, so that research is still out. So let's look at this. We're talking about the dorsal respiratory group, DRG, okay? These dorsal respiratory groups set the rhythm. Isn't that a strange word? Rhythm, to spell? It doesn't look right to me. I looked it up. That way I know it's spelled right. But they, thank you, Google. Dorsal respiratory group set the rhythm, and this rhythm is caused by a slow leak of sodium. So just like in the heart, we have pacemaker cells, right? Like the SA node. Here we have this slow leak of sodium, and we'll leave it at that, and it sets sort of this pacemaker rhythm. Now, how this does this is it's through another just vocabulary, chemotaxis. Chemotaxis is a movement of an organism due to a chemical response. So this organism moved due to a chemical response, and then this chemokine signals proteins. I think that's misspelled. Is that E-I or protein? P-R-O-T-E-I-N? Huh? Yeah, I got that. So that's right. That's a book right. Anyway, spell it as you wish. But signal proteins secreted by cells to induce chemotaxis. So this chemokine signals these proteins, okay, to start this action here. And we've talked about the chemoreceptors before, briefly, right? These chemoreceptors are in the aortic bodies, which is they use different nerves. Like the aortic body uses the vagus nerve, the carotid bodies, they use a different nerve, but these chemoreceptors sense the level of pH and the CO2 levels. See, we have this all the time. That's what's amazing about the body. It's all the time, because homeostasis, right? It's always fighting to maintain homeostasis, and it's doing it through all these signals and transmissions through these different ways to do that. We would go nuts if we sat down and really thought about all the ways that worked. You guys, who wants to go in neuro? Yeah. You're going to go nuts. Okay? Because at some point in time, it just becomes too much, right? So we get these chemoreceptors, so we say, okay, so we have it, it's controlling the pH and the CO2 levels, okay? And then we have these mechanoreceptors, which controls the pressure, mechanic, right? That's the way I remember it, mechanical. So we have the mechanoreceptors control the pressure, nose, the lungs, the GI tract, some of them are in there. And then we have stretch receptors in the thoracic wall and also in the airways to let us know, hey, we're full. We can't handle anymore. Just like our tummy, we have stretch receptors there, even though we can overpower those, right? All the time. Yeah. I'm full, I can't handle any more bluebell. Shut up, I don't care. I'm eating it anyway. Alright? So we have these stretch receptors, and in here, this is sort of the way that it controls respiration. So we stepped, at first we said, okay, we left it in our anatomy review, we left it on the brainstem controls respiration by the respiratory groups and the pons, right? And the medulla. And the thoracic cavity has to increase its size in order to get air in, right? And all that. You remember that? And that was a simplistic way of looking at it. Very true. A simplistic way of looking at it, okay? And now we just add another component here where we talk about the dorsal respiratory groups. When will you ever use this information? I don't know. However, what is important for us to remember, especially in medicine, is why. Why does that happen? Okay, we don't have to ask why all the time. That patient dying in front of you doesn't care that their dorsal respiratory group is not firing correctly, okay? But at some point in time, when things get really tough to figure out in patient care, we have to go back to the physiology and look at the physiology and say, okay, why is this not working? Why? Why is the body doing that? Why is that patient doing that? Okay? So the physiology answers the why, and sometimes that's very important. Sometimes it doesn't matter, the why. Okay? It comes down to, let's save this person's life first, and then figure out the why. Let's do this. It's like algebra, right? If you think about why in math, in algebra, you're going to have long years in math. Okay? I was told that early on in my mathematical nightmare. Alright? Don't. The smartest woman in the world told me this, by the way, my chemistry professor. She had to be the smartest woman in the world. I sat really close to her in class so I could get a brain cell here and there. So dropped off. Dr. B was her name. Is her name. I hope she's still alive. But she's old then. She's really old now. But anyway, she was a doctor, had her doctorate in chemistry in Cuba. And they didn't recognize it in the United States, so she went back and got another one.
What?
Yeah.
Wow.
So she was hugely smart. She gave me some really good advice early on in chemistry. She goes, don't worry about why or the numbers, just do the math so you can get the grade. All right? Do the problem. Solve the problem so you can get the grade. And when I had trouble in algebra, she did the same thing. She goes, don't worry about why, just solve the problem. Solve for x. The why here is not really important. The thing that's important right now is to get the number right so you can get the grade. Worry about the why when you don't have the stress of getting your grade, right? So, anyhow, very good advice. I took it and ran with it. I did all my time in algebra. I didn't care why. I just solved problems, which I actually liked to do. Didn't like the math, but anyhow. So that's this. That's this part here. Now we have in this inspiratory ramp pattern. Okay. That's just the name of it, but it falls down to what's called an I to E time. Inspiration to expiration time. I to E. When you do your rotations with respiratory, you're going to see this. They're going to set I to E times on the ventilators. Okay? So on that vent, you're going to have I to E times. If you want to jack somebody up really quick, mess up their I to E time. I've done it before by accident. It looked really cool, but that SpO2 goes bam. And so you have to fix the I to E time. Inspiration to expiration time. The normal I to E time is 2 to 1. And that's measured in seconds. 2 seconds in, 1 second out. Okay? You can adjust those I to E times if you want for several reasons. Okay? And I will refer you to your respiratory therapist when you go. When they're working on those vents, like in the SICU, and they're setting the vents, say, oh yeah, by the way, what about those I to E times? And they'll give you the look like, wow, okay, you're bored. But have them just explain that to you. Right? That's why we go there, so they can explain the deeper things in respiratory that are out there. Okay, so, good? Everybody good with this?
Yeah. For the top part with the CO2 and pH, you said to identify acidosis for CO2 is more than 45, and then for pH is less than 7.35?
Yes.
And then for alkalosis, is it the opposite?
Right. Alkalosis is less than 35.
And then more than 7.45.
Right. Okay, good. Okay, let's take a stroll down memory lane. Right. Little history for you. There's this myth. Now this is not myth down at the bottom. Okay, this is fact. There's this little myth about COPD patients. Okay, you will still hear this because people still live in that myth. Okay, they live in the same myth about oxygen, and everybody needs oxygen. You know, everybody needs nasal cannula. That's a myth. It's only been 10 years. Okay, this has been probably a little shorter, a little longer. I don't know, but there's this myth about COPD patients, really bad COPD patients, like that real bad emphysema patient, they live on the hypoxic drive. Now we break this down to where it's a little bit more simple as well, okay? Because we have this thing called, hold on. We come to the curve. It's gone. I'll think of it in a second. Anyway, these guys live in they say these guys live in what's called the 50-50 curve. Oxyhemoglobin curve. Woo-hoo. Okay, one more day out of the nursing home. Good. Oxyhemoglobin curve, right? So you have this oxyhemoglobin curve that adjusts back and forth depending on situations in the body. It adjusts due to body temperature, right? It adjusts due to CO2 and O2. So you have this oxyhemoglobin curve that will adjust, and they live at 50% in there, all right? Just keep that in mind. A little trivia, really. We won't go into that because we don't need to. But these guys live in the 50-50 club just like the zipper club, right? These guys have an open heart. You can tell they're in the zipper club. So these guys live in the 50-50 club, and the myth was that they live on the hypoxic drive. What's the other drive that we breathe off of? Except you're the chronic smoker, right? Oh. Hypercarbic drive, right? We breathe, normal people, non-smokers and smokers, they breathe on hypercarbic drive. They breathe in response to CO2. Now the myth makes sense in theory. It really does, okay? But they've proven it wrong. But I'm telling you that there's probably still people teaching that, and I can tell you the older people in medicine, they still believe it because they don't read and do their research and stuff, okay? But anyhow, so they believe these people in the 50-50 club, they live on this hypoxic drive, not the hypercarbic drive. The hypoxic drive is a backup drive, so we can keep breathing. The body does amazing things to keep the heart going and us breathing, okay, us living. So what the myth was, okay, is that you have this COPD patient, severe COPD patient, and that you can't give them oxygen, or you shouldn't give them oxygen by a non-rebreather mask, okay, because you will increase their FiO2, the fraction of percent of oxygen, right? So we breathe normally, what's our normal FiO2? Room percent oxygen. What do we breathe in? 21. Right, 21%. We put a non-rebreather on a patient, we increase their FiO2 to what? The percent of oxygen, the non-rebreather.
90 to 95.
Right, 90 to 95. We've switched this FiO2 from 21% to 90 to 95. Okay? So here's how the myth goes. Since we have sort of that foundation, is that if we have this patient, I'll set up a little scenario. We have this patient that is a COPD patient. They're in extreme respiratory distress. We believe that they're, because of the way that we were taught back in the day, we believe that they were breathing on their hypoxic drive, their backup drive, not their hypercarbic drive. So they're breathing away, and the myth is if we put this and they breathe the hypoxic drive, the myth was that they breathe on response to oxygen. Okay, it's just everybody's starting to put this together now. That was an important fact I left out. Hypercarbic drive response to CO2. Hypoxic drive in response to oxygen. That is true. Okay, so they believe that if we put this non-rebreather on this patient that is having severe respiratory distress, this COPD patient, that they're going to stop breathing. All right? Because they breathe on the response to oxygen. See what we did? We had a patient that breathed 21%, and their body's going, oh, 21%. I'm breathing, right? And they breathe on response to that oxygen. We put a non-rebreather on them, and now we've raised their FiO2 90 to 95%. Why did they stop breathing? That's close. Too much oxygen, right? Why? Why did they stop breathing? That's getting there. That they're not used to that much oxygen. That's closer. We're playing that game closer. Further away. Let me just tell you so we can get out of this nightmare, okay? They stop breathing because the body they don't need oxygen anymore. They were breathing at 21%. And just use the numbers. They were living on 21%. You have a job, right? And you make $21. Alright, and you need to work to make $21, correct? If someone all of a sudden gives you $98, do you feel the need to work anymore? No. No, you just gave me $98. I don't feel the need to work. Yeah, so I'm used to living on $21, and all of a sudden someone gives me $98. I sure don't feel the need to work, right? How many times is that? Almost 5 times, right? If you do 100, right? So a little less than 5 times. If you increase my pay by 5 times, I wouldn't show up for work. I'd take off. I wouldn't need to work for a while, okay? And that's what the body does everybody sort of get that? That's what the body does, is it say, oh, I don't need to breathe. I'm at 98%, boom. Good deal. And they stop breathing. If they stop breathing, is that a problem? Let's ask it again. If they stop breathing, is that a problem?
Yes. Yes, because of the carbon dioxide.
Oh, no, don't overthink it. Let's go back to the KISS principle. If they stop breathing, is that a problem?
Yes.
Why do y'all keep saying yes?
Yes.
No.
Is a problem. You wouldn't breathe.
Is it because you already had enough oxygen?
Now you're overthinking again.
I need to process this slowly.
Making it simple.
Okay, let's ask the question again. If they stop breathing, is that a problem?
Oh, no. Oh, no.
No. I'll breathe for them. That's not a problem because I'll breathe for the patient. They're still breathing, right? I've never taken a patient to the hospital without a pulse, right? Because someone has, even if their pulse is stopped, someone's always doing this, right? CPR, their compression, so they have a pulse. They stop breathing, it's not a problem. It's not a huge problem. I'm going to breathe for them, okay, until we can figure this thing out, all right? So that's the myth. And this, I've taught that for decades, okay? It's wrong. It's just wrong. They finally came out and said, hey, this is what happens. Now it's fairly close, but it's not correct because we're basing everything on oxygen. Okay? So the simple version of this is the Haldane effect. You will hear about that later in life. Haldane, this was a guy, okay? Harry Haldane. I don't know if his name is Harry, he just Haldane effect says that a decrease in oxygen, let me get my notes so I don't mess this up. Deoxygenated hemoglobin, I can't understand my own abbreviations. Deoxygenated hemoglobin, okay, causes a greater affinity. Affinity would be what? if you have an affinity towards somebody, right? An attraction. Did you say attraction? Yeah, attraction, right. You have an attraction. So an affinity is an attraction. Okay? So deoxygenated hemoglobin has a greater affinity to CO2. Alright? So if we do what we just talked about and we increase this person's SpO2 by putting a non-rebreather on them, okay, or FiO2, if we increase this, it's going to decrease the affinity to CO2. Where's that CO2 going to go if it's not on the hemoglobin? Not in the blood. Right. It's going to go into the vascular system, okay, which increases this. It increases the pH. Okay? It's going to increase the pH. So what we're doing here is when we take this guy with this PCO2, the PCO2 is just like the PO2. PO2 is the amount of oxygen in arterial blood. Okay, the normal PO2 is what? 80 to 100. Good. So the normal PO2 is 80 to 100. So we have this patient with the PO2 of 60 to 65. They're real acidic, right? Their SpO2 is hovering around the 88%, which is okay. That's where they normally live. All right. So if we increase their SpO2 because we get scared of this number here, this 88% on this COPD patient, okay, and we increase their SpO2, we put that non-rebreather on them, what's going to happen is it's going to cause a release, a less affinity, and the CO2 is going to go into the bloodstream, okay? Because when we give oxygen, it decreases respiratory rate. Right? If we decrease the respiratory rate, we increase the amount of CO2. Does that make sense? So if we do that to this patient that's already really acidic, okay, then what's killing this patient or what's making them stop breathing is not the amount of oxygen, but the amount of CO2. That's a big difference, okay? Because our standard of care, we never withhold oxygen from a patient that is in severe respiratory distress. You want to enter into that courtroom scenario, do that. Withhold oxygen from a patient in respiratory distress. Okay? So it's based on the amount of carbon dioxide, not the amount of oxygen. See the way it sort of flipped? All right? So now treatment-wise, we need to say, well, how can we get rid of this carbon dioxide? We need to get rid of that CO2. We need to adjust the acidosis here. So it's an acidic problem. It's not an oxygen problem. And the hypoxic drive is a weak drive. It really is a weak drive. Like you have a weak acid. CO2, I believe, is a weak acid. But it's been too many years since chemistry. Dr. B would slap my hand. Bad chemistry. But I can't remember. CO2 a weak acid? You guys have had chemistry sooner than I have. Do you have strong acids and weak acids? Yes. CO2 a weak acid? Wow. Would you have to do?
And I hated myself for like 1 year.
I have a reason not to remember. I'm old. And that was back, I think, before you guys were born. Alright? So, but anyway, no big deal. So, this patient, if they are in this hypoxic drive, okay, they are unconscious. So we have more problems than whether, they breathing on their hypoxic drive, right? because they're unconscious. They're critical. Any unconscious patient falls in that critical thing. So this patient's we have to control their airway. We have to figure out why they're unconscious, right? We have other fish to fry instead of saying, oh, I wonder if the Haldane effect is causing their unconsciousness. Right? Who cares? Protect their airway, right? Figure all that stuff out later. Don't let the patient die thinking about, theory in physiology. Do the mechanical stuff. So if they're unconscious, protect their airway. Breathe for them, perhaps, right? Make sure they don't aspirate. Be ready to suction. All these different things with this unconscious patient that we can do in the interim while we're figuring this out. Now, this patient here, they're unconscious and they're going to go in and they're going to draw an ABG, right? Arterial blood gas. They're going to look at the values on that. Then they're going to adjust their treatment based on what they find in the labs, what they find on their exam, right? Find out from their history. All right? Everybody good with that? So, not a huge thing. It's just I wanted to clear up that myth because the older person that you ask about that, they're still going to believe this. They're also going to be the ones who say, "Oh yeah, oxygen. Everybody, give them oxygen. They're having a heart attack. Give them oxygen." Right? That's not true. Evaluate the need for oxygen. Right? Decrease SpO2 less than 94%, right? Or outward signs of respiratory distress. So always evaluate the MI patient, the stroke patient, the trauma patient, all the same. You give them that unneeded oxygen over a long period of time, then you're going to worsen whatever case that they have. Okay, let's take 5. Then we'll switch gears into asthma.